Coming to the renal clearance, what is the formula for renal clearance or for any substances? It is UV by T, that is UV by P. What do you mean by renal clearance? It is the measurement of renal excretion. It is the measurement of renal excretion ability. How much excretion is done? Whatever plasma that came, whatever got filtered, how much of it got excreted? That is nothing but your clearance. And how you calculate that? By the formula UV by P. The most accurate substances to calculate this is the inulin. So let's see, what do you mean by U? U means the urinary concentration of the substance. Any substance over here, the inulin is taken, right? So urinary concentration of the substance. V means how much rate is there for that substance to come towards the kidney, that is in the urine, that is urine flow rate, right? And the P denotes the plasma concentration, right? So that's how you are going to calculate the renal clearance of any substance. So you need three values, that is urinary concentration of that substance, that is U. You have to multiply it with the urinary flow rate that is present in the body, that is V, and P is the plasma concentration. Now, if we have to put this reabsorption and secretion into a formula, what we calculate by this is the urine output, right? How we calculate? The amount filtered minus amount reabsorbed, right, plus amount of the substances. So amount filtered output is equal to amount filtered minus amount reabsorbed plus amount secreted, right? So that's how we calculate the output, right? That means how much it is filtered, you have to subtract the substances which are reabsorbed. Why? Because they are no more in the urine, so you have to subtract that, because you are taking the urine output. How much is in the urine, you have to say that. And if something is secreted into the urine, that means it is increasing the volume, so you have to add that amount of secretion. Now, glucose reabsorption, it is very, very important. Glucose is giving us the energy, right? So we want that to get absorbed fully. So how much glucose reabsorption is done? Almost 100%. If the renal threshold is not crossed, what is the renal threshold? That we will discuss, but just for now, remember it is getting absorbed 100%, right? And most of it is done by the PCT. Most of the work is done by the PCT via secondary active mechanism. Secondary active transport, right? We just now talked that there is something known as renal threshold. What is that? Everything in our body has some limit, right? So the glucose absorption is also having a limit. Suppose a day a person can eat 1 or 2 kgs of laddus, right? The glucose is not going to get absorbed, because that much of energy is not required in the body and that much of receptors for the absorption. Since it is secondary active transport, it is secondary active, that means it is absorbed with the help of someone, that is nothing but the sodium. So there must be some gateways for that, channels for these sodium and glucose to get absorbed. So they are known as sodium glucose transporter. This S is for sodium, GL is for glucose, and T is for transport, right? So these channels are limited, so they can absorb some limited amount of glucose at a time from all the nephrons, right? So that limit is known as the renal threshold. That means there is a threshold to absorb this glucose, right? And the maximum amount of glucose at a time which is absorbed, that is known as your T max. maximum amount of transport possible at a time is known as your T max, right? So what is the renal threshold? The renal threshold is 300 milligram percent, right? And what is the TMG, transport maximum, is the 375 milligram per minute. Just remember this number. This is also important for the exam purposes, right? So we say the maximum amount of the glucose can be absorbed is 375. But remember, as per the exam, right? So you have exams and you told that maximum number can be possible to achieve is 100 marks. But how many of us got 100 marks in the our UG times, right? Almost nobody. Why? Because they ask some questions which are beyond our like study material or something like that. So similar happens over here. All the nephrons do not have this Tmax. Some might have less marks also in the students, right? Similarly, some nephrons have some less Tmax or less threshold. So what happens is, though theoretically the Tmax is this, right? But in practical life, the Tmax become much more less, or you can say even the threshold is much less. What is that? 180 mg percent. So this threshold and this Tmax becomes very less. So the difference over here, the theoretical purpose is 300 mg and the practical threshold is 180 mg. The difference in between these two is known as renal splay. So if our paper goes very easy, we expect to have something like 90 to 100 marks, but what we actually get in UG times, like 60 marks or 70 marks, right? So something like that. We expect the renal nephrons to absorb 300 mg percent, but all the nephrons not having the same capacity to absorb the glucose. So that's why the Tmax or the threshold goes very low. At the average, it becomes 180 mg percent. Coming to the sodium reabsorption, remember they ask about the maximum sodium reabsorption and we discussed that happens in the PCT, almost 70 to 80%. Then 50% happens in the DCT and 2 to 3% happens in the CD, that plus DCT, right? So what happens over here is that maximum is absorbed into the PCT and minimum is absorbed into the collecting duct, right? Okay, so moving on to the water reabsorption, we know that maximum, again the main site is the PCT. What about the other sites? Loop of Henle also helps in the absorption, that is 10 to 15%. Then 8 to 10% is absorbed into the DCT and 10 to 12% is absorbed into the CD. Now you can see in the DCT the absorption is very less as compared to the CD. Usually what happens is in the proximal parts you have more reabsorption. But since the CD, the collecting duct, is in the medullary part and medullary osmolarity is already high, right? And that's why it is easier to absorb the water from that area, right? And we have something known as aquaporins. What are those? Those are the channels through which the water is going to get absorbed under the action of ADH, right? So that's why, and these channels are present in the CD. So both reasons, first is the medullary osmolarity is high and second is the aquaporine channels which are present in the CD part, and that's why you have higher reabsorption in the collecting duct. The next phenomena is glomerular tubular balance. What is that? The ability of proximal tubule to reabsorb the constant fraction of glomerular filtrate of the solutes, right? Filtrate and the solutes delivered to it. What do you mean by that? We know the percentage, right? Suppose someone got 10 marks and someone got 100 marks. Who is better? Suppose the person A or student A got 10 marks and a student B got 100 marks. Who is better? The people will say that the B student is better, but I did not tell you out of how much, right? The student A got the 10 marks out of 10 and this student B got 100 marks out of 500. So obviously you get to know that this student A is performing better, right? So that's why if I would have told you the percentage, then you would have easily identified, right? So A student got 100% mark and the B student got 20% mark. So now with the percentage, you can easily identify how the efficient working is there of those students. Similarly, whenever we talk about the kidney, we talk in terms of percentage, right? And that is nothing but your fraction. We talk in terms of fraction, that how much amount of filtrate is there and how much amount of that is constantly getting reabsorbed, right? The relative numbers are giving the a false value or false, you can say, conclusion. So we talk in terms of the fraction, right? So that is nothing but the glomerulotubular balance. Why it is known as glomerulotubular balance? Because how much it came to the glomerulus via the afferent arteries and how much the reabsorption is done via the tubules, that is your PCT, DCT and loop of Henle, they all are known as tubules, right? That is why it is known as glomerulotubular balance. How much it came to the glomerulus and how much of that value is got reabsorbed, that we check in this. This balance is usually used for the check of the sodium reabsorption. So that is glomerulotubular balance. There is something known as tubuloglomerular feedback. The opposite of that, tubuloglomerular feedback. What is that? It's a feedback mechanism. The tubules are giving feedback to the glomerulus. Suppose if excessive amount of filtration is there, that means the GFR, if it increases, what will happen? If the filtration increase, the filtration must be containing all the solutes, that is mainly the sodium and chloride, right? So filtration increase. If the filtration increases, what happens? There must be increased number of sodium chloride, right? This tubules having a specific sensors which sense this sodium chloride level. That is nothing but your macula tensa cells, right? The tubules will sense those increased level of sodium and chloride, and they will tell it that there are much more sodium chlorides are coming, and that's why they get to know that yes, the filtration is much more. So what they do is they give the feedback, and this tubules will inhibit the glomerulus via secreting the renin and activating the renin-angiotensin system. So what will happen? Once this sodium and chloride levels are high, they are going to secrete the renin. They are going to tell the glomerulus system, right? And this renin will activate and form the angiotensin 2 ultimately. And this angiotensin 2, they will cause the constriction of the afferent arteriole, right? And that's how, if you constrict the inlet, what is going to happen to the output? Obviously that is going to decrease. So the GFR is decrease back to normal, right? So that's how the regulation is worked via the feedback mechanism. So both the things are different. So remember that whether the examiner is wanted to ask you the glomerulotubular balance or tubuloglomerular feedback, both are different. If they talk about the balance, then you have to talk in terms of constant fraction that is getting reabsorbed, right? If the feedback word is there, then you have to think in terms of the feedback system which is given from the tubules towards the glomerulus. Okay, the next is concentration or dilution of the urine. That depends on your majorly on your loop of Henle and some part on your the collecting duct, right? So let's see what is this. The kidneys can adjust the extracellular water. We talked about various parts and compartments of the body fluids in the general physiology. One was the ECF, that is extracellular fluid, and this kidney can manage this extracellular fluid, whether they can increase it or they can decrease it, right? How? Via doing the changing the concentration of urine. So either they can concentrate the urine or they can dilute the urine. If they dilute the urine, means more and more water is excreting out, so the blood volume will decrease. If concentrated urine, means solutes are much more and water is less. Where those water is gone, the water got reabsorbed into the blood, so the blood volume will increase, right? So they are maintaining this volume of the ECF. If there is too much extracellular water, what is going to do? It is going to change and it is going to excrete much more water, and it will decrease the ECF volume back to normal. How? Via excreting more water, right? It will throw out much more water. If excess is there, what you do? You excrete the water and volume will be come back to normal. What if we are having less water in the body, too little water, or the person is dehydrated? What will happen? More and more water will be absorbed, so increase the water absorption, right? And because of that, what will happen? More and more water will be getting reabsorbed into the ECF, so ECF volume will increase, right? And over here, what was happening? When it was too much, we were secreting much more water into the urine, so much more water was secreted or excreted, so volume will be low. So that's how they maintain the volume via concentrating or diluting the urine. The next topic is ADH. ADH also controls or regulates something which is known as osmosis. How? Via the aquaporin 2 channels. We know that there are aquaporin 2 channels. Where they present? In the collecting duct, and that's why we discussed that the water absorption is much more in the collecting duct. What happens? Suppose this is the collecting duct which is having only few amounts of, suppose this is the collecting duct, right, and it is having 3 channels for water reabsorption, right? So suppose already it is having only 3 channels for water reabsorption. So how much amount of molecule? Suppose 1 molecule is only getting absorbed per second, so only 3 molecules can come inside. But what this ADH will do is that ADH will put more channels to it. So more gates will be available for the reabsorption, right? So suppose this ADH, what it will do? It will create much more holes and it will put channels over there. So at a time, what can happen? Much more water molecule can come inside, right? So suppose over here, it attaches much more gates, right? So it attaches 7 gates. So at a time, rather than absorbing only 3 molecules, the collecting duct can absorb 7 molecules. So that's how, via putting this aquaporin 2 channels, aqua means water, pouring means the pore which is allowing the water molecule to get reabsorbed, that is known as aquaporin. So the ADH will put this aquaporin channels onto the tubules so that more and more water will get reabsorbed. Now, what if too much, suppose too much ADH is secreted, what will happen? If too much ADH is secreted, that will lead to something known as SIADH, that is syndrome of inappropriate ADH secretion, right? So what happens? ADH is much more increased. So what will happen? It is beyond the normal level. So excessive amounts of aquaporin 2 will be put on the tubules, and much more water will be reabsorbed, right? Which is not required for our body. So what will happen to the volume of the blood? The volume of the blood will increase. But what will happen if the water is increased much more, but the solute levels was normal? So what will happen to the osmolarity? That will decrease, right? So what happens in this syndrome of inappropriate ADH secretion is that the osmolarity, it is going to decrease, right? So normal we talked about 285 to 295 milliosmol per liter, right? This will go much lower, right? And opposite will happen if the ADH secretion is low. What will happen if the ADH secretion is low? Low ADH secretion, that will lead to less absorption of water, right? So less absorption of water means absorption is less. That means whatever water is there, that is going to go into the urine and that will come out of the way through the urethra. So the urine volume will increase, and the person has to go for urination again and again. This disease is known as diabetes insipidus or DI. In this, what is the problem? The ADH is secreting much less, so much urine volume is produced, and the urine water excretion is much more. So what will be the problem in this person? This patient will present with the dehydration and polyuria, right? Okay, that's what it is telling over here. If the ADH is high, it will give the SIADH disease, right, which concentrate the urine, right? Why? Because more and more water is going to get absorbed, right? Then what about if the ADH is low? We talked the large volume of dilute urine will be formed. Why? Because less and less water is getting reabsorbed. So we talked about the auto regulation, how it is going to get regulated. If the GFR is increased, you can see the blood flow is also increased. That means if the high blood flow is there, it will increase the GFR also, right? So that is nothing but your auto regulation. So let's talk about the auto regulation. What about the auto regulation? That means your blood pressure and renal plasma flow that we talked in the last slide, right? Suppose there is a change in the BP. Suppose your BP is increased, right? What will happen? This will be sensed by your cells which are known as mesangial cells, right? So this will be sensed by the mesangial cells, right? So I'll write it down over here. This increased in the BP will be sensed by your mesangial cells, right? So what happens once you sense that there is a higher BP? What happens is there are some changes which occurs in the nephron, right, to maintain the BP. So how it is going to be maintained? Afferent arteriolar relaxation will be occurring. So this is your afferent arteriole, right? If you increase the diameter of this afferent arteriole, suppose this was like this before, if you increase the diameter, right, what is going to happen? The blood flowing into this afferent arteriole will increase, right? So more and more blood will come over here. But at the same time, what happens is there is efferent arteriolar constriction. The exiting out gate is constricted. So what will happen if you suppose the first the lumen was this much and now it became much shorter. So what happens? More and more blood is coming, but it is not able to go out, right? So what will happen? It will find some another way. And what is the another way? If it is not able to go from here much of the blood, because more and more resistance because of the efferent arteriolar constriction, so blood will get filtered into the Bowman's capsule, right? If more is the filtration, what is going to happen? So more is the filtration, that is more your GFR, right? And more will be the urine formation. So much of your volume is lost in the urine. So volume of blood will be decreased and volume of urine will increase, right? So what happens due to decrease in the volume and pressures are directly proportional in the CVS system, right? So as soon as the blood volume decreases, the blood pressure also decreases. So that is the mechanism over here. So change in the podocytes and capillary surface area, that is going to occur over here, and altered oncotic and osmotic pressure, that means change in the Starling forces is going to occur over here, right? So that is the mechanism behind the autoregulation. Okay, so let's discuss about the counter current mechanism. What is this counter current mechanism? Is that you can see there are two things. This red one is the vasa recta, right? And this one is the descending you can say loop of Henle, and this one which is going above is the ascending loop of Henle, right? So what is this counter current mechanism? As the name suggests, counter, that means opposite. What is opposite over here? So you can see the blood is flowing from here to here, right? The direction of flow is like this, and the direction of urine formation is exactly opposite to that of the blood flow, right, in the vasa recta. So this red one is the vasa recta and this is the loop of Henle. The direction of flow of blood into the vasa recta is opposite to that of the flow of the urine into the loop of Henle. So that is nothing but the counter, right? This is the counterpart. That means the direction of flow is opposite. What do you mean by current? So even the direction of the flow is opposite, but you can see over here that these two are placed parallelly. These two are placed parallelly. So that's why that is known as counter current mechanism. Current means they are placed parallelly, parallel to each other, but the direction is opposite, right? So the direction is opposite, but they placed parallelly, right? So how it is going to create our counter current mechanism? Let's see. So we said that this is the descending loop of Henle, this is the ascending loop of Henle. What happens is, you can see the descending loop of Henle, near over here, the water, only the water is going to get reabsorbed. So you can see only water molecules are getting reabsorbed into the blood, right? So what is going to happen? Only the water molecules are going to get reabsorbed. That means over here you can see the osmolarity is going to get increased. Why? Because more and more solvent is gone and more solutes are remaining inside this tubule, right? So osmolarity increases, right? And what happens over here in the ascending loop of Henle is that you can see sodium chloride potassium channels are there, or you can say sodium potassium 2 chloride. There is channels which are present in this ascending loop of Henle, that is they are known as sodium potassium 2 chloride. Why sodium potassium 2 chloride? You can see this is also positively charged ion, this is also positively charged ion. So 2 positive ions are getting reabsorbed. With that, either you need to secrete 2 positive or you have to reabsorb 2 negative, right? So 2 negative are reabsorbed. So the electric balance is also maintained via this tubules, right? So this is having this ascending, especially thick ascending loop of Henle. It is having this channel, right? So what happens? More and more solutes are getting reabsorbed. So what will happen to the osmolarity? You can see the water is not getting reabsorbed in the ascending, right? But the solutes are getting reabsorbed. So again the osmolarity will decrease, right? As you go up, the osmolarity over here is decrease, right? So these two things are opposite. But why such things are happening? Remember, the descending loop of Henle is permeable only for the water, and ascending limb of loop of Henle is permeable only for the solute. How to remember? D for D, right? What do you mean by D for D? Descending loop of Henle drinks water. Remember that, right? So you can remember D for D, that is descending limb of loop of Henle drinks water. So what do you mean by that? Descending limb of loop of Henle is permeable only and only for the water, not for the solute. So as it goes down, much more water is getting reabsorbed. But over here you can see that it is not placed into this interstitial fluid. So this is the interstitium. The blue color is interstitium of the kidney, right? So what happens? The vasa recta is running parallelly to this. This water molecule suddenly goes into this vasa recta, and the vasa recta will reabsorb this water, right? In the case of the you can say the ascending loop, you can see some molecules are secreted in the interstitium also, and some molecule will get reabsorbed into the vasa recta. So what will happen due to this? If some of the sodium, potassium and all those ions, chloride ions, are there inside the interstitium, the interstitial osmolarity is going to get increased, right? The interstitial osmolarity is going to get increased, and we know that loop of Henle is the part in the medulla. So when they talk about the medullary osmolarity, it's always and always going to be much higher than the cortical part of the kidney, right? So osmolarity is higher because of this ascending limb of loop of Henle, right? So it is increasing the osmolarity. So that's why it is known as multiplier, right? That means normal osmolarity of this interstitium is 300. Because of this ions, it becomes 1200 at the tip of this loop of Henle, right? And that's why what happens is, once this 1200 is there, that means it is increasing. If you multiply this 300 by the 4, you will get the 1200 value, right? So that's why we say this descending limb of the ascending limb of loop of Henle as the multiplier. How it is helping in the water reabsorption? So remember, because the high osmolarity is there, as soon as this water comes over here, this interstitial osmolarity is higher and it wants to maintain the osmolarity between the tubule and interstitium, so it will absorb more and more water. So it helps in the absorption of water, right? And vasa recta, if suppose this vasa recta wouldn't have absorbed the water from the interstitium, what would have happened? The osmolarity, this osmolarity will get back to its normal, that is 300 milliosmoles, right? But we do not want that. We want much water to get reabsorbed. So what we do, whatever water is reabsorbed into this interstitium, we suddenly send it to the vasa recta, so that the vasa recta will reabsorb it, will take it and put it into the blood, right? So vasa recta is known as exchanger. Vasa recta is known as the counter current exchanger. And what is the function of this vasa recta? It is maintaining the osmolarity via exchanging the water molecule. So that's why it is known as exchanger. So the same thing, the long loop of Henle, which is presenting which nephrons? It is present in the medullary type of nephrons, which are going deep into the medulla, establishes the vertical osmotic gradient. If you see in the diagram, over here there is a gradient, right? What is the gradient? So over here you can see that the gradient over here is increased. So see, first of all it was 300 over here, then 500, 600, then 900 and 1200, right? Similarly, it is going, as the loop of Henle is going down or vasa recta is going down into the medulla, the osmotic gradient will increase, right? And as they are coming out over here, 900, 600, 500, 300, and similarly in the loop of Henle also, so that will, as they are starting to come out into the cortex, the gradient of osmosis will decrease, right? So as you go deep, the osmotic gradient is increased. As you go up, the osmotic gradient is decreased, right? So whatever gradient is established, that is established by this loop of Henle, so that's why it is known as counter current multiplier, right? Because it increases much 4 times more osmotic gradient at the tip of the loop of Henle, and vasa recta will preserve the gradient via absorbing the water quickly, right? So that's why it is known as counter current exchanger. So just remember these two names. They ask about what is multiplier, what is exchanger. The exchanger, when they talk about, they are talking about the vasa recta, and they talk about multiplier, that means they are talking about your loop of Henle. So that's all about the renal system. Thank you.